and it's a pleasure to present the different two instrument sets that we have. And one of them was discussed by Professor Aruz and Dr. Fazal. So this is a modern OR. This is the Vitum 3D that we discussed about, which we have outside. We're going to have the chance to see it together today, which is an Exoscope 3D digital camera that can give you the chance to work on a monitor instead of binoculars or loops, and with a high magnification, a good clarity image, as well as the remote control, where you will be able, of course, it's covered with a sterile cover. And this we see also the tower, which is coming on a pendulum. And the good thing is that, the nice thing is that it's a thin the arms that are holding the monitors that can move in different directions. And here also we have a telecast from the OR, whether endoscopic image or an outside camera, and to an external monitor or computer using internet, via internet. So KAL stores, we didn't venture into stabilization, into fixation, into implants. We don't have that. We just have instruments, reusable instruments, autoclavable instruments for decompressions, whether stenosis or herniated disc. This is the spine tip, which has 3 scopes that can be used in upper and in thoracic surgeries. Easy Go, which is particular, it's a dilation, and then tube. It's a minimal invasive approach that is common for most of you. It can be used in both lumbar as well as in the cervical spine. So these are the main 2 sets that are being requested by surgeons and used. And then we have the endospine, which is an old system that we had. We still have it. And then we have the thoracoscopy, which is also an area that is not very developed. Still, it's underdeveloped, and only few surgeons are actually interested in that area. For example, I covered the whole MENA region, so all the East Mediterranean part, starting from Turkey, Iran, Pakistan, to the Middle East, to all of Africa. We have only 1 surgeon in Jordan, 1 surgeon in Morocco doing thoracoscopy, disc hernia on the thoracoscopy lateral approach. So it's still an underdeveloped field. I'm gonna slip these slides, and I'm gonna move directly to the first system, which is the Easy Go, targeting the lamina. It can be done under fluoroscopy. Some surgeons, they do it even without fluoroscopy because they can flip the lamina because it's a short distance coming interlaminar. And this is an access that even open surgery, you know it. It's skin, facial muscle, lamina, ligamentum, flavum, and then disc space. So with the first small dilator, and then we dilate over it, and then we dilate over it. This is the orange, which is 15 millimeter. So we can have the small trocar, or we can continue. The black, it's a dark color, and then the green, which is the 19, or we can continue to the black, which is the 23. In this case, the 19, the green, and then the cannula has been put, and then it will be fixed on an arm, on an autoclavable mechanical arm that we saw also the day before yesterday. So now the dilator will be removed, the cannula is in, fixed on an arm, 2 free hands. Now, this is the axis. Either a microscope can be put, or the Vitum 3D, the exoscope that I talked about and we're going to see today, can be placed for microscopic discectomy, microdiscectomy, or we have the telescope holder and then we put the scope inside. And then we work through the cannula while looking at the monitor, we work through the cannula. Advantages of this system is, the name is Easy Go. Easy, it's easy to implement because the access is common to orthopedic and neurosurgeons already having experience in spine surgery. It's a common approach. Second, for big cases where the PELD cannot treat, like stenosis, some big stenosis cases, the Easy Go, you can see better, you have more space to work inside. So that's another advantage for the system. This is how it looks. This is the instruments coming inside. This is how it is in live surgery. This is the cannula placed, and then 2 free hands, suction and other instruments that get inside. I have many surgeons that they use both. They have the Easy Go for the interlaminar approach for some specific stenosis cases, and then they have the PELD for the transforaminal or the posterolateral approach that they use it for herniated discs or or even for stenosis, but which can be treated from the transforaminal or the posterolateral. And also, in addition to the interlaminar, also Professor Joachim Ortel, who visited Kenya in 2014, he also uses the same tubular as well to access the foramen. He just goes a little bit laterally, okay, to access the foramen to treat lateral, not far lateral, but mainly lateral disc hernias. It is possible.
German guy.
He's a German guy, yes.
We were together in Istanbul.
Yeah.
1 week before.
And he's a fun person to be with.
Yeah. He made an lecture on actually 2 laminars. I mean, he got into lamina, burr, and take the fragment out. Very interesting. With this, all migrated. You start the lamina, not take the lamina. Just make a hole.
A hole just to enlarge a little bit to get an access to inside. Yeah.
That's also a good concept for stenosis, the easy go, whereby I can try compression. It's called over the top decompression. If we have lateral recess stenosis on the opposite side, contralateral. So you can actually, with the table, you can turn the patient and you fix the dilator. And also turn this tube. Also turn the tube, and you drill the spinous process, base of the spinous process, until you can see the nerve root on the opposite side. Right?
There's a surgeon in the UK, actually in the UK. He uses the easy go for big tumors on the brain. Where they look, yes. Believe it or not, and in the UK. Where you know that healthcare is very well controlled off-label, but he uses it. But he's from Lebanese origin. So this is the old generation where it was 45 degrees angle, the telescope. Sometimes the camera, when it's connected here, it used to come in the way of the surgeon. So to have it like more as a bayonet shape, so now it's 90-degree curve, the new generation where the camera is connected here, so it doesn't interfere with the instruments while working. So this is the modification that has been done. So this is how it looks. This is the camera. It's oblique, 45 degrees, while here it's 90 degrees. So you have free space while working. The second advantage of the EasyGo 2 over the 1 is a bigger space for working, which was taken by the scope before. So now we have a more enlarged, a wider window to work from with the EasyGo 2 system. Also, we do have a silver book on EasyGo by Professor Ortel that details very well the different indication that can be done, different pathologies that can be treated. A DVD as well is available that also has several surgeries being done, stenosis, hernias on multiple levels as well. We'll be more than happy to share with you as well. So this is the technique. It's almost 1 finger, 1 to 1.5 centimeter from midline, the classical approach that you know. Moving into percutaneous endoscopic discectomy, or known as PELD, percutaneous endoscopic lumbar discectomy. So I'm not going to go into technical details because we heard already, and we're going to get another nice talk by Dr. Ouz. So just to talk about the instrument side. The spine tip stands for transforaminal, interlaminar, posterolateral. Transforaminal blue, interlaminar is the red, and posterolateral is the green. Optimal is to have the 3 scopes. Sometimes it's not possible, okay? Sometimes for budget constraints, like for example, Dr. Fazal, Dr. Kasmani, they invested themselves in the red scope only. So the red scope is a 25 degree, it's 18 centimeter working length with a 3.6 centimeter, 3.6 millimeter of working channel inside of the scope. While the blue scope is 25.5 and 25 degree also angulation, with the same diameter, also 3.6. So this and this are very similar, but the only difference is the length. And this is what Dr. Ouz showed in the fat patient. He said 170 kilograms. This is the scope that he used that can, for large patient, it can be useful. Now for thin patient, even this scope, because well, there was a question by Dr. Kasmani to Dr. Ouz, this scope can be used also transforaminal for normal patients, okay? And then there's the green, which is the posterolateral. It's 15 degrees angled. And why it's 15 degrees angled? And this is what Dr. Lubers say, and I would like to know also from Dr. Who's about your experience. He says that going with the green posterolateral, this is the true posterolateral scope and not the red. Because red is 25 degrees, this is 15 degrees. With the green, after finishing the inside out, he goes out in to see the nerve roots. And with the 15 degrees for him, it's much easier to visualize the nerve roots because he wants to see the nerve roots. He wants to make sure that the nerve root is completely decompressed. So this is according to Dr. Lubers. What do you think, Dr. Lubers?
And one thing is that another important thing is with this Luber stick, I'm using also Luber stick. You use the straight, round, working cannula.
The straight working cannula. Yeah.
If you use 25 degrees, the vision can be obscure because it's not up, open up. Yeah, you understand me? You have to look straight.
Dr. Wuz is saying this is an oblique cannula. You see that? This is the working cannula. Now, for this case, you're saying that for the posterolateral, you use the closed cannula.
Yes.
So with the closed cannula at 25 degrees scope, it might obscure the vision. You will not see because you have the tip of the cannula that will be hiding some of the image, right?
Yeah. And also, they show that.
Sorry, please.
And also, one more problem is, if you use the oblique one, when doing foraminoscopy for extraforaminal discs, we use foraminoscopy, which means you enter the foramen and see exiting nerve root. If you use this one, it's dangerous. The nerve can enter this blunt area, this oblique area. But if you use a blunt one, straight one, nerve cannot enter where you're working.
So it's hidden.
Yeah.
Okay.
Yeah.
So always
that's the reason.
where you're
so
working is
you have to look straight.
Okay. So that's why the 15 degree would be useful. Okay, it's good to know. Good to know. So this is the transforaminal, which is the long scope, but also the red scope can be used from the same for the same approach for thin patients. This is the interlaminar approach, and this is the posterolateral approach. Already this has been discussed: MRI, placement, dilator, working cannula, and then MRI, and then scope over it, and this is the end results. This is the Gore technique, which is Dr. Gore is always convinced with the posterolateral only. Okay, he doesn't go transforaminal, he doesn't go interlaminar. Some of the students of Dr. Gore, they use sometimes the interlaminar approach, especially for the L5S1. But Dr. Gore, for all of his cases, he goes posterolateral and always inside out. Even when the fragment is medial, he goes inside out and he catches it from inside. He has a philosophy. I'm sure that he explained it to you. The fragment out, he takes it out when he sees the bleeding going out of the disc, because inside of the disc is no blood. So he knows that the fragment has been removed, the total fragmentectomy has been removed. And also what Dr. Fazal was mentioned about the red at the end of the fragment, that means that he had enough pieces. So it's a different school. It's a different school. I mean, if it works for him, that's great. If it works for Dr. Lubers or Dr. Ooz or any of you, it's also fine. So these are the pumps. We have the irrigation pump, which is reasonable in price to do a good irrigation during spine surgery. And then we have the dual pump, which is irrigation and suction. So you can have both irrigation and suction on the same scope. And same from the PLD, we have the silver book from Dr. Lubers, from Dr. Thomas Lubers, who explains the 3 different techniques, the interlaminar, posterolateral, and transforaminal, with the surgical videos also that is nice on each of the approaches that details the techniques. So thoracoscopy, just one slide to mention that we have this system. It's an interesting area. And if you ever see the surgeons operating, the experienced surgeon operating, this really nice procedure can be done. Tumor removal, fragments removal, herniated disc, stenosis. It's actually interesting, but these are long procedures. Surgery, blood transfusion is needed. Sometimes general surgeon is with the orthopedic or the neurosurgeon to do the operation. And yeah, so thank you very much. Any questions? No. We move to Dr. Ooz. Dr. Khalif, is it still sharing?
Yeah.
Okay. You see my slide now? No? So it's not sharing. Do you see it now?
Sorry?
Okay. Dr. Woos, please. Before we start, there was a question. Who asked me the question about the blue color? I think it was you. So we had a question that in the video of Dr. Woos, there was a blue color with the fragment that was going. So the question was, Dr. Woos, is it from the light? Is it the reflection? Or what is this blue color?
It's indigo carbon. I said I do discography in every case. And I use half 3 millimeters of indigo carbon and 3 millimeters of radioparticle and make it 10 millimeters of solution with saline. So indigo carbon stains the pathological nucleus and guides you through the operation. That's why they are blue, not because of reflection.
Methylene blue, you can use methylene blue.
Huh?
You can use methylene blue also.
I know methylene blue is not that much specific to discs, and indigo carbon is it likes acetic medium, so just go to methylene blue, you see everything blue. But indigo carbon goes to pathological nucleus. Look at some questions. I want to Martin,
Yeah.
Do you think I now explained the technique or in cadaver, whatever you want?
I think it's better now to do it theoretically because the cadaver might be a challenge. We're going to try, but it might be a challenge. But I think
the trajectory. Of course, as Mother said, there's different schools. Dr. Gori and this Lubers who trained me and Dr. Rutan, they all love extreme lateral. The philosophy, I'm going to tell about the philosophy between this. As you, Dr. Fazal, is he here now? No. No. With the posterolateral technique, so I can say anything, yeah? It's nothing. Okay. This is, the epidural space. This is the PLL. And this is the cyst, right? If you are in a posterolateral trajectory, you come like this. Yes?
yes.
I'm not going to come like this. So in the video, we saw the same, the PLL, the epidural space, and the disc space. Yes, that's true. But you can have this vision only when you enter. You understand me? Just enter. Just if you are here, the beginnings of PLL. So if you go, if the fragment is here, if you go, you are always going away from the fragment. So you cannot take this fragment. You just look. You see. Maybe you can use the 90 angle too, but you can never do it. It's not easy to manipulate. It's not possible.
Even if you take complete removal is very difficult.
Yes.
Even if you take
You can take this PLL, yes. Better vision. But when you enter, if this has fragments in the midline, you never take it. It's impossible. So the main difference in the technique I am using, I go like this. I can draw it here. Do this. You understand? And I said, in the vision, this PLL should be in the lower part of the vision endoscope. So if you take it, come, it doesn't matter. You are always epidural. This is the philosophy under epidural technique. In this technique, if the disc is here or here, you're lucky. And in contained discs, maybe you can take it. But for extruded disc, castrated disc, you can never reach this place. It's impossible. So sometimes some guys use PLL, posterolateral technique, and also adds foraminoplasty. This is the philosophy. If you do follow foraminoplasty, you can do it here like this and see the accuracy.
So how do you come? How do you come that? You see, we saw the working. Huh?
I don't know. He is really asking. Always asking, but no. The entrance point is really important. On the AP, as I said, the drawing may not be good, but this is this space, yes. And if there's an iliac bone, I have to come like this, yes? So I make a mark on the patient to my trajectory on the AP, yes. And I turn the scope lateral, and on the lateral, these are the facets. Yes, I put my right here and make another drawing line, and this line where they intersect. You understand? It's my entrance point, and the inclination is almost 5 to 10 degrees. Yeah, because I want to be epidural. Yeah, in PLL, posterolateral technique, you have seen that the inclination is like this. In my technique, the inclination is like this. So entrance point is here. Then you decide the inclination, see AP, and when you touch the facet, see lateral, and go in the facet and go in the disc. And you have asked, normally, the puncture point should be medial pedicular line and posterior vertebral line, yes? And he said, your always pin is like here. This is why I saw that picture. Yes, I puncture here, but even I go, it is still here. You understand? Otherwise, I should see like this. When past the midline, the pin should be here. In the posterolateral technique, you will see here. But you have to see here, even you advance your working condition.
So are you subannular or you are supraannular? You are supraannular.
Most of the time, supraannular or just annulus. I see in the below the half of the screen. So I cut some and stay almost supraannular. And before finishing, of course, I go increase my inclination, go in the nucleus, take 3 fragments.
Anybody has question? Please ask any question. I wanted to ask about you go posterolateral sometimes.
Yes, for extraforaminal.
Extra
only.
So you go directly on the fragment, posterolateral.
No, I use the Lumbar stick. So I go just in the nucleus and come back and turn to foramen. it's safer.
So it's a combination of inside out, outside in. It's a combination of both.
Actually, there's two main techniques. You can put your working cannula and endoscope to pedicule, okay, inferior pedicule, and find the disc space and go to find the exiting nerve root. This is the technique. You use oblique one. This is the Rutan's technique. Lübeck's technique. You go in the disc, go out, and turn to foramen. And it's safer there. And then look for the fragment.
Excuse me, when you're doing the turns, you're doing them under porosity.
Excuse me?
When you're doing the turns, you're doing them under porosity.
Time for fluorescence.
So you're timing when you're doing the turns.
I still don't understand.
What you need to
Saying, are you using direct vision or are you using fluoroscope to guide you?
For a monoscopy, no. Just check it after I'm in foramen, checking with endoscopy. But normally, with endoscope, endoscope and the working cannula in, I go outside and I see annulus. When I see annulus, I barrel like this and go to foramen. And after that, one shot, if I'm in the foramen or not. Just one shot. So,
It's ready.
in some cases, I have to use interlaminar, especially really sequestrated, up migrated, and L5S1 cases. Sometimes my friends tell, why are you forcing transforaminal? Because sequestrated and down migrated or up migrated discs are really hard to do with transforaminal. And my answer is, they are hard to do also with microdiscectomy, with interlaminar technique. These discs are hard. It is not because of transforaminal is not effective. These discs are always hard to solve, even with microdiscectomy. You have to take a lot of bone, and sometimes you finish operation, you say, oh, okay, I am satisfied, and the fragment is there, missed fragment. For L5 anatomy, L5S1 anatomy, for L45, it's not a problem, but the iliac bone is a real issue for L5S1, especially in some cases in male patients, as my colleague told, it's a problem. And as he also told, sometimes you can enter from the same entrance and do L5S1 and L5, okay? But one thing he said, I'm really not happy here, but he said, if you cannot enter L5S1 from your trajectory, just try to do, no, you are going to do L45. They are the same place, he said. You remember?
Yes.
I don't accept it, actually, because if you cannot enter from here, it doesn't mean that if you enter from as if you are doing L45, then you can find your way. Never do then transforaminal. Go interlaminar, microdiscectomy. Because entering to this doesn't mean that you are going to take the fragment out. You have to place your working cannula to the exact place. It's, I think, very important. Transforaminal, as I said before, is sometimes hard for L5S1 because, the iliac bone, big facet, and everything. But interlaminar is a good technique for L5S1, as most of the time the interlaminar window is very big. So you don't have to take bone out. Yeah, you don't have to cut bone. So in case transforaminal is hard, I think this technique should be chosen. And as an endoscopic disc surgeon, in the very beginning, I was against interlaminar. And actually, most of the endoscopic surgeons, when you ask, they say, I'm transforaminal guy. The others say, I'm interlaminar guy. And they do one technique, apart from Dr. Rutan. For an endoscopic surgeon to be successful, has to do both techniques. It is a must, because if this is impossible, then you're going to do open surgery. No, you can use interlaminar technique. I told about the anatomy. Actually, I didn't know that I'm going to, pardon, I'm going to make a lecture about interlaminar. So I gathered all my, data together. For posterolateral transforaminal technique, it can be foraminoplasty transiliac. Interlaminar technique can be used as a shoulder or axilla. The techniques differentiation is this. Ligamentum flavum is protected, is resected. Annulus repair not possible. They say possible, but according to me, annulus repair is not possible also with interlaminar. Just annular sealing is possible. I'm going to tell about it. And indications are limited. Indications are wide, because you can do any operation, especially now. I am sure you have heard unilateral biportal endoscopic discectomy. They do any case, even degenerative spine, central canal stenosis with this technique. And fibrosis, as I said before, minimal, not reported. With interlaminar technique, it's possible. Anesthesia can be local, epidural, or general. With local, it's not comfortable. Motor block with local is, a bigger problem when you compare to general without muscle relaxants. Root irritation is possible with local, with general, no. Wake up is possible with local, and with general, not used. The position is a little bit different for interlaminar. The patient is hip flexed, lumbar flexed, and you should put your hand to the back and feel the straight or the rigidity of the soft tissue, which means that you open the interlaminar area and the ligamentum flavum is tight. If it is not tight, it's impossible to, not impossible, but very hard to cut ligamentum flavum with endoscope. So you put your hand here and tell the assistant, bend, bend, bend. When you're satisfied, you can begin the operation. And also what Dr. Rutan told me, never think that, okay, it's not rigid anymore, but I will do it. It doesn't occur. He say, position again the patient, and then begin. Position is really important.
When is your starting point? It's soft?
It will be tight. Tight, very tight.
That's your starting.
Yeah, because that means interlaminar window is widened and the ligamentum flavum is tight. So when you cut, it's easier. But when it's soft, it's really a big problem.
So it means that to have it tight, it means as if I'm standing like this.
Yeah, yeah.
Yeah.
Flexion, flexion, flexion.
So that's why the window is open in that case.
Yeah.
The vertebra is
Yeah, yeah.
Okay. Makes sense.
The incision is just lateral. very close to spinous process, and your target is here. This is really important, my friend. You have to enter ligamentum flavum very near to fascia. Otherwise, you will end up with neurological problems. 100%. So your target point is here. So you are going to make the ligamentum flavum incision here. Distal oblique is really good actually, because when you push the ligamentum flavum, make it tighter and you can cut it easier. And also you give less muscle injury. You can see the axilla with straight one, it's very hard. And you can ecartate the dural sac with this, working canoe, but it needs little expertise. There are different techniques. Resection, which I also use, it's easy and classical. Choi, indirect blunt puncture. I tell you a lot, it's very important to be lateral. Just going with a needle. Really, I have seen it. Just go in with a needle. Blunt entrance. But he go very lateral and he says, there's no neural structure there. But I never tried and I will not try. Direct puncture, in this technique, they go to the ligamentum flavum and put the endoscope, and with sometimes RF, they make a hole, and the water pressure takes the neural structures out and then cut. This is logic. Learning curve is for shoulder, it is short. For axilla, it is flat. Inferior migration is difficult in shoulder, but easier in axilla. You can imagine. You can see the fragment if it is down migrated. Superior migration is easy in shoulder. I have never seen superior migration in axilla, but it's difficult. Root retraction is strong. There is no root retraction in axilla. Just you can take the sequestrated fragment. Annular sealing, which you open the annulus. So with RF, you want to shrink the defect. This is called annular sealing. It's easy in shoulder, weak in axilla. This is, axillary approach. This is shoulder approach. Most of the time in L5-S1, this is shoulder discannation. This is what you see. You take the neural structures and the fragment is here. This is the axillary view. You see the disc fragment here. Just take some epidural fat here and you see the disc fragment here. This is a patient. Today, maybe I would do it transforaminal, but it was a big one, so can you see? Yes. I will show the video. For L3-4, the interlaminar window is not big. First, you take the ligamentum flavum superficial, and you have to cut some bone, the shoulder of the lamina, just to widen your window. You see, some guys take the flavum before this procedure, but I believe it is more safer to keep this deep ligamentum flavum and then do the bone resection, because it protects the neural structure, and then cut ligamentum flavum.
Okay. So how do you stabilize your sheet here?
You hold it.
Oh, okay.
With one hand, yeah. And after taking some, this is the ligamentum flavum. Now we are going to enter. You see, when water comes in, all the neural structures goes down, and you have some working place, safe place. And then use the knife. You can see the neural structures. Sometimes there is epidural fat, but you can take with punch and you can see this. And as I said before, the important thing is go as far lateral as possible. Yeah, this is very important. Use calyces, and you have to go lateral to this root. Otherwise, you cannot ecartate anything here.
But your incision is close to the spinous process, 1 centimeter.
Yes, but you go laterally this way, yeah, and use electrocautery just to, you know, and this root is always displaced, not in normal place, because of you have experience with microscopic surgery, so you know this is here. I can see it, but I have to ecartate the root. And I will do it with the working canoe, but I need little place more just to put the oblique working canoe. Yes. I have to prepare here and put the beak there, so turn it and the neural structures go midline. Yes. You see? Now I'm going to put the canoe, working canoe. I saw because I can, you know, ecartate. Yes, I'm putting it. Oblique side looking to spinous process. I was not successful, so we'll try again. No, I was successful, and you know the disc came here, yeah, yeah. There's the nerve structure. It's you must control it just by turning it. As you use it as a joystick, and now I took the disc inside. Nerves are all midline, so I can really work safe. And you always relax the nerve roots in every 3 or 5 minutes.
Here you're using the straight canal.
No, oblique, always oblique.
Interlaminar, always oblique.
Yes.
Transforaminal, oblique.
Oblique. Posterolateral, straight, yeah. Now you will see the, you know, the remnants of the disc. Take them all out. These are not modifications. These are 2 different operations.
How much of the disc do you take?
Huh? Just take the fragment, and then enter the use. Sometimes you cut some annulus. Sometimes the fragment, the ruptured area is enough. So enter in the disc and take loose fragments. That's all. You see? Now it's more easy to ecartate. There's a fragment also. So take it out. And under, you see? Under the annulus. You have to look there. And after that, I will do some annular sealing. I mean, with RF, I will try to decrease the ruptured area. turn the working canoe, and yes, this is annular sealing. And also this is very important for post-operative MRI. If you leave that, they sometimes think this is, you know, missed fragments. Now I'm going to show another interesting case, L5S1. Can you see the window?
Yeah.
Yeah. And the iliac bone here. And it guides these interlaminar. Transforaminal is not good for this case here. Very big interlaminar area. The placement of the things. And you know, maybe you think this is not a big one. But can you see the root here? Just pressing the root. I'm going to show in the video. You cannot believe. Just root is like this, and this is like this. Yeah. So the patient was really painful. Look. Take some superficial ligamentum flavum, enter in, again go lateral, just this place you have to dissect. It's very important. You see the root is high, and now please look. This is just under the root, really pressing one, and eccartated, but comes again. You see the fragment, small but really displaced.
Oh.
Yeah. And the operation the classical way. Conclusion, especially for L5S1 cases with high iliac crest, high cranial migration. This is the main problem because we do it minimally invasive, but cut the ligamentum flavum. It's very similar technique and anatomy with microdiscectomy and shorter learning curve. Thanks for your attention. Yes.
Nothing more straightforward. It's just the traction factor. Which due to neuromonitoring.
No.
So you put in the retraction, you put in the retractor, and then you push in the sheath again.
Yeah.
So the sheath, first of all, is outside. It's just interlaminar.
No. It's just very, very close to nerve structures. You know, this is the ligamentum flavum. Same like this. You put the retractor, dissect it. Put it lateral to the root, and enter, oblique side looking to the root, and then turn.
No transient weakness or anything like that.
No, actually, you know, even if I'm not sure in the root, I do bipolar and see the muscle. Yeah, no problem. Even I do bipolar on the root, nothing happens. Yeah. And also, it's very important, retract the root and do operation half an hour. No. Relax it.
Relax.
Relax it. Go back.
So the entrance are half centimeter, and 1 centimeter paramedian.
Just feel the spinous process and the three, just near it. And go, the spinous process, go like this.
Up to the facet.
Yes. And I always put the thing to facet and come here. you feel warm.
Okay. So same thing, needle.
No need.
No needle, yeah, because the interval.
No.
So how
No
do you
need.
start with
In my technique, no need. But
dilator only?
yes,
Only
but
dilator?
as I said, Choi just puts the needle. It's nothing, but this is.
So in your
probably
technique, you start, how do you mark? You don't use a needle, so you mark, you make an incision and go with the dilator,
yes,
and then a sheet.
yes, yes.
Dilator, you get all the muscles out, just because there is only one dilator, not like
When I feel the facet will come to the down, I do my operation like this, just to take the muscles out of vision.
and then you put the sheet.
And the sheet, and then begin to take the remnants of the muscles and see the ligamentum flow, and after that take the superficial ligaments, and then see the, the orientations are different. And when I think that I'm in deep ligamentum flow, I just press little to the ligamentum flow and cut till I see the nerve structure. And after I see the blood water comes in, presses, and so I work.
And all this time it's moving.
Yes.
The sheet is moving.
So who's regarding the cannula, I just wanted to, because it wasn't clear for me. So this one is the closed, you mentioned this one is the closed cannula.
Yes.
This one is
Big one.
big, and this is oblique.
Oblique.
So which one you use for which approach?
This is for posterolateral.
Okay, and that's why you said
Just-
that the 15-degree scope can
Yes.
be equal.
Just for extraforaminal disc herniation.
Yeah.
Lateral and extraforaminal. Then I use this one, both interlaminar and transforaminal.
You don't use this one.
I never actually bought it, so I don't have it.
But I think this one are very similar, no?
Yes, but this is better. For especially in interlaminar, I think you cannot use that one.
Transforaminal, interlaminar is the oblique. The posterolateral uses the closed, which is set safer on the nerve. So, and Dr. Wuz, just as a piece of advice for a surgeon who wants to start, or a surgeon who's done 5 to 8 cases, what's your advices for patient selection, for complication avoidance? What do you tell us to be careful about?
Very good question.
First time you tell me something, but you always tell me I don't do.
Actually, for content and if it is widely contained, I mean, if the disc herniation is wide, don't touch. Don't touch because the recurrence rate is very high in that case. So you can miss the fragment and you can really have a lot of recurrences, which really diminishes your morale and energy. And I really try not to operate contained discs. I operate seriously discs, extruded discs. So the best case is a laterally placed extruded disc, laterally extruded disc, not on the midline, and not migrated. And because if you enter even posterolateral, as I told here, or if you enter extreme lateral, you most possibly will see the fragment. So a laterally placed disc is a better choice, sequestrated, but not migrated. Yeah, and most of the discs are that type. And the very first cases should be L4-5 and L3-4. They are easy.